For joining today's CMS Web Interface support call. During today's webinar, CMS will provide an overview of 2019 CMS Web Interface quality reporting for MIPS groups and ACOs. And after the webinar, CMS will take as many questions as time allows. So now I'll turn it over to Sandra Adams-Slaughter to begin.
Thank you. Welcome, everyone, and thank you for joining us today. I'm Sandra Adams-Slaughter from CMS. Joining me on the call today are other CMS experts and contractors who will share helpful information on CMS Web Interface quality reporting and answer your questions during the question and answer session after today's presentation. Today's call will only focus on quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Next slide, please. This is a disclaimer slide about this presentation. Information in this presentation was current at the time it was published, but I urge you to please be sure that you're using the source documents and links that are provided throughout the presentation. And please stay tuned to any communication from the Quality Payment Program, Medicare Shared Savings Program, ACOs, or Next Generation ACO model regarding any updated information. Next slide, please. And now the recordings, slides, and transcripts for the January 22nd call are now available on the Quality Payment Program library. Next slide, please. The submission period for the CMS Web Interface aligns with other submission types for 2019. Opening on January 2nd, 2020, and closing at 8 p.m. Eastern Daylight Time on March 31st, 2020. Your submission will automatically be accepted at the submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website circled here. Next slide, please. As you may know, today is part of a series of web interface support calls held weekly through the data submission period. The next support call will be held next Wednesday, February 12, 2020, from 1 to 2 p.m. Eastern Standard Time. Topics will include measure FAQs, but will also be primarily Q&A. The measure FAQs that will be discussed on the next call include CARE 2, Hypertension 2, PREV 7, and PREV 10. Additional topics may be added prior to the support call. Next slide, please. This is a reminder that the other CMS approved reasons skip requests must be submitted through the CMS Web Interface. This is a way to skip patients attributed to a measure during denominator confirmation. The CMS approved reason is reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified in the measure specification. Patients for whom a CMS-approved reason is selected will be skipped, and another patient must be reported in their place for the measure, if available. Next slide, please. The CMS Web Interface API is available all year for testing in the developer preview environment. You can review the resources listed on this slide for more information. Next slide, please. And now I will pass it off to Kara Sokol to discuss assignment and sampling FAQs.
Good afternoon. This is Kara Sokol, and I will be highlighting a common question regarding the web interface sample for quality reporting. Next slide. The question is, why are there beneficiaries in our ACO sample for quality reporting that are missing any clinic ID or NPI? In the web interface, up to 3 providers are pre-filled for informational purposes only to assist in the collection of medical records. When there are no pre-filled clinics or NPIs, there can be concern that this indicates a sampling error, but this is not the case. Rather, it is expected that there will be some beneficiaries for which NPIs or clinic IDs are not populated. This can be for several reasons. The beneficiary may have been prospectively assigned or voluntarily aligned and have not yet received primary care services from the specialty used in assignment, but have received at least 2 primary care services overall and therefore qualified for the sample. For more information about data submission via the CMS Web Interface, you can refer to the Web Interface FAQs on the QPP website. Thank you, and you can proceed to the next slide. The next section is a discussion of Prep 12.
Next slide, please. For CMS Web Interface users, with an electronic health record, EHR, that currently currently have documentation that reflects the 2018 Prep 12 measure specifications, CMS will accept the same type of documentation you submitted during 2018 submission period for the 2019 performance year. Similarly, if your current EHR has been developed based on the 2019 Prep 12 measure specifications, CMS will accept documentation that aligns with the 2019 measure specifications. For questions that are specific to your organization regarding acceptable documentation, please submit questions to the Quality Payment Program Service Center at 1-866-288-8292, Monday through Friday between 8 a.m. and 8 p.m. or by email at the email address listed on this slide. Next slide, please. And now Angela Stevenson will go over some frequently asked measure questions.
Hi, this is Katie Moore from the PIMS team. I can go ahead and speak to the frequently asked measure questions for today. Next slide, please. So the questions on this slide are related to HTN2 controlling high blood pressure. The first question is a blood pressure reading from a remote monitoring device acceptable for 2019? No, blood pressure readings directly from monitoring devices are not acceptable for 2019. Question 2, are blood pressures captured by a nurse or specialist accepted? Yes, the blood pressure may be taken by any clinician in the organization that is qualified and for whom the eligible clinician or group clinically manages. Question 3, what if there is a history of essential hypertension in the patient's medical record, but it appears to become resolved? So for this measure, the denominator confirmation requires a diagnosis of essential hypertension within the first 6 months of the measurement period or any time prior to the measurement period, but does not end before the start of the measurement period. So in essence, your medical record documentation should support the diagnosis of hypertension resolved prior to the start of the measurement period. You would not confirm that patient. However, if the diagnosis was active during the measurement period, in that instance, you would confirm the patient. Next slide, please. This slide covers MH1 depression remission at 12 months. Question 1 is, can you clarify the time frame for the denominator exclusions? So for this measure, patients with an active diagnosis of bipolar disorder, personality disorder, schizophrenia, psychotic disorder, or pervasive developmental disorder any time prior to the end of the measurement period may be excluded. Patients who were a permanent nursing home resident any time during the denominator identification period or the measurement period would also be excluded. Next slide, please. This question is regarding Prep 12. Does a certain condition, for example, intellectual disability, impairment, Alzheimer's, dementia, autism, qualify a patient for a denominator exclusion? For this particular measure, the denominator exceptions are not defined by specific diagnosis. So if the patient qualifies for the measure and there's medical record documentation that the patient was not screened due to situations where the patient's functional capacity or motivation to improve may impact the accuracy of the results of the standardized depression assessment tools, then it would be appropriate to select the denominator exception. So for this specific example, the denominator exception could be claimed if there's medical record documentation stating the screening was not performed due to the patient's diagnosis. Next slide, please. Now I'll hand things back over to Sandra Adams to go over resources and where to go for help.
Thank you, Katie. Over the next few slides, we will outline the available CMS Web Interface resources. Please note that the 2019 material providing information on the MIPS performance category are available in the Quality Payment Program Resource Library. We encourage reviewing these resources if you have questions on quality requirements and measures. We'll continue to communicate any future postings and upcoming support calls. Next slide, please. The QPP Resource Library also contains recordings, slides, and transcripts for past Quality Payment Program webinars, including the recent 2019 CMS Web Interface user demonstration held in November and the CMS Web Interface kickoff call held last December. The recording slides and transcripts for January 15th and 22nd calls are also available in the library. While the date on the library for the January 15th recording currently reads January 28th, please be assured that this is the January 15th call and we are working to make the correction. Please note it may take 1 to 2 weeks to post the presentations to the library following a webinar. Additionally, the help and support page on the QPP website contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. Next slide, please. This slide contains links to resources available for the Medicare Shared Savings Program ACOs and Next Generation ACO models. We encourage you to review the materials available here and sign up to each newsletter for more information. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. Next slide, please. Please help us to improve the Quality Payment Program experience. Now, just before we head into the Q&A portion of the call, if you're interested in providing feedback and collaborating with CMS on the Quality Payment Program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest and organization to the QPP user research at cms.hhs.gov. And now I will hand things over to Ketchum to begin the Q&A.
All right, great. Thank you so much. So now we'll start the Q&A portion of the webinar. You are allowed to submit questions two ways. You can do so by submitting a question via the questions tab on your screen, and we will read it out loud for everybody to answer. Or if you'd like to raise your hand by clicking the hand icon to the left of your go-to menu, we can go ahead and unmute your line. And when we go to unmute your line, we'll just say your name first so that you're aware. All right. So the first question is from the chat box. And it does read, for Press 7, if the only documentation we have is a claim for the flu vaccine, is that acceptable for the numerator?
Hi, can you please repeat that question?
Of course. It says, for Press 7, if the only documentation we have is a claim for the flu vaccine, is that acceptable for the numerator?
So this is Katie. For purposes of meeting the numerator, unless that date is pre-filled within the CMS Web Interface, we would need medical record documentation supporting that the flu vaccine was administered. Claims data alone would not be acceptable medical record documentation. Thank you.
Great, thank you. All right, your next question concerns HTN2. It asks, if a patient was diagnosed with hypertension in April of 2019, but the diagnosis was changed to white coat hypertension 1 month later, the patient, i.e., did not take any meds, should that patient be counted?
So this is Katie again. We have quite a few questions related to HTN2 coming through and what an appropriate diagnosis would or would not be for the measure. So it really comes down to confirming that the patient was diagnosed with essential hypertension during the measurement period, within the first 6 months of the measurement period, or any time prior to the measurement period. And again, it cannot end before the start of the measurement period. So it would be the responsibility of the organization to confirm that the patient did have an appropriate diagnosis. We can refer you to the hypertension coding document for a list of proper diagnosis for the measure. But just to reiterate, if the patient does not have an appropriate diagnosis, which would be essential hypertension, according to the coding document, and that's supported by your medical record documentation, then you would not confirm that patient. Thank you.
Great, thank you. All right, your next question asks, are Alzheimer's patients excluded from MH1?
We also have quite a few questions coming in on MH1 regarding two specific diagnoses that can be excluded from this measure. So Alzheimer is not listed as an appropriate exclusion for MH1. The exclusions can be found on page 6 of the 2019 MH1 measure specification. So these include a diagnosis of bipolar disorder, personality disorder, schizophrenia or psychotic disorder, pervasive developmental disorder, and then patients who are permanent nursing home residents. So these are the only applicable exclusions for MH1s. I will also point you to, if the patient did not have an active diagnosis of major depression or dysthymia during the denominator identification period, which is November 1st, 2017 to October 31st, 2018, or if they did not have a PHQ-9 during that denominator identification period. In those instances, you would not confirm that patient anyway because they didn't have, they're not considered denominator eligible, either due to not having the appropriate diagnosis or not having PHQ-9 completed. Thank you.
All right, so we'll go to the phone line for the next question. Abigail Wenland, we are unmuting your line. So Abigail Wenland, you can ask your question.
Awesome, thank you so much. If this was actually about MH1 as well, I believe you just confirmed it, but when we're talking about the denominator exclusion time frame, you're saying that if the patient did not have a diagnosis of depression or the other ones that you mentioned during that 2017 to 2018, I'm not going to go into the specifics here, but is that the time frame we're talking about? You mentioned a measurement period and then another period, so I want to make sure I get the exact dates.
Sure. So for the denominator exclusion, for patients with an active diagnosis of, well, it's really all of them except for patients who are nursing home residents. Those need to be any time prior to the end of the measurement period. So it's any time prior to December 31st, 2020, that those exclusions would apply. So for patients who are permanent nursing home residents, that would be any time during the denominator identification period, which is the November 2017 to October 2018, or during the measurement period. And that date could potentially vary by the person if they did have that index date. But if you're looking for more specifics on a certain scenario, you can certainly submit that to qpp@cms.hhs.gov, and we can take a closer look at that for you.
Great, thank you. All right, next question is also from the phone line. So Deborah Barnhart, we're unmuting your line. And Deborah, you can go ahead and ask your question.
Thank you. My question is related to Prev 7. Each year, our organization orders and distributes flu vaccine to the primary care and select specialty physician practice. Prev 7 has 3 denominator exceptions, including documentation of systems reasons vaccine not available. In the event that one of our physician practices, and we have a lot of physician practices in our organization, runs out of vaccine, and if a patient is in the office and they determine that the patient has not received a flu vaccine, should they document vaccine not available? Or in other words, is that the intent of the vaccine not available definition?
Hi, this is Deb. Are you able to hear me?
Yes.
Awesome. Okay. The answer to that Prev 7 question is if in the office that particular facility has run out of the vaccine, you are able to go ahead and select the system exclusion. That is there for those cases when people run out of the flu vaccine.
Okay, very good. Thank you.
Thank you.
All right, great. Next question is about Prev 10. It asks for tobacco use if the patient chart says smoker in the last month and non-smoker a month later. Is he or she considered a non-smoker?
Hi, this is Angie from PIMS. You would use the most recent patient query for the measurement year if there is more than one. Use the most recent during the 24-month period. Thanks.
Great, thank you. All right, next question concerns the FIT DNA test. It asks, a Cologuard test was collected September 18th of 2016 and resulted January 3rd of 2017. Does this meet the numerator for Prev 6?
Hi, this is Angie from PIMS. The test must actually be performed or collected during the measurement period or the 2 years prior to the measurement period. Thanks.
All right, great. Just a general reminder, we see a lot of hands up to ask questions over the phone line. If you would like to ask a question over the phone line, please connect to audio to do so. So right now, we will go ahead and unmute the line of Lisa Tishona. So Lisa, you're unmuted and you may go ahead. Lisa Tishona, you can go ahead and ask your question.
Oh, am I on your link? Hello?
Hi, did you have a question?
Hi, yes. This is for Prev 12. As I understand it, a clinician is supposed to assign whether a number represents a positive screen or not. However, if there is no written affirmation of a positive, are we to mark no when asked if the screen was positive for the measurement period?
Hi, this is Katie. Can you please repeat that question?
So for Prev 12, we're supposed to, the clinician or the doctor, whoever does the depression tool, administers the depression tool, is supposed to assign whether the number that comes up, whether that is considered a positive or not. And if they don't document whether that particular number represents a positive test, are we supposed, but there is a number there, are we supposed to go ahead and mark no when the asked if the screen was positive?
So in this situation, the measure does require a clinician's interpretation of those results. So the only instance where anything could potentially be assumed, at least for 2019, would be if a PHQ 9 or PHQ 2 score was 0. If there is any other numeric value, that would require a clinician's interpretation. So in this case, we would suggest perhaps going back to that clinician to determine whether or not that screening was positive or negative.
And this is Sandra Adams Slaughter. I would suggest that you please submit your question to the Quality Payment Program Help Desk.
Great, thank you for that clarity. All right, next question also concerns Prep 7. It asks, do we have to document every year that a patient still has an egg allergy?
This is Deb from the PIMS team. Yes, we do have confirmation that that should be documented during the flu season or regarding the flu season that's being measured. Thank you.
All right, great. All right, next is about Prep 13. It asks if previous documentation of a statin allergy, so in this case from 2018, is no longer acceptable. Does that mean that the patient is expected to try a different statin every year to see if they have a similar allergy? And is allergy documentation expected to be uploaded yearly in the EHR?
And this is Deb again from the PIMS team. Where I would suggest you look, first of all, is on page 14 of the posted document. It does require that the denominator exception is considered active during the measurement period. So you would need to have documentation that the reason that the statin was not prescribed during the measurement period was due to an allergy. So that allergy has to somehow be identified as active. Thank you.
Great, thank you. All right, one more question about Prep 7. If a patient declined an influenza vaccine between August 1st and September 30th, would this count as a denominator exception, or would that patient have to decline again between October 1st and March 31st?
If your documentation identifies that the flu season that they are refusing for is that current flu season that's being measured, it's fine. You don't have to get them to refuse during the October through March time period. Your documentation just needs to support that they are refusing the vaccine for the appropriate time period.
Great, thank you. All right, we have a few more questions from the phone line. So Theodora Masseri, we have unmuted your line and you may go ahead.
Hi, thank you. Can you hear me?
Yes, you may go ahead.
This is for Prep 12. If an ACO has a policy in place, do we need to find documentation for interpretation of the results if they already have a policy in place regarding what each score indicates?
Hi, this is Sandra Adams Slaughter. Could you please put up slide 11? Thank you. So for Prep 12, here's some information that you may find helpful. For CMS Web Interface users with an electronic health record, we are currently accepting the documentation. I'm sorry, did someone have a question? Sorry, I thought I heard a noise. Anyway, we are currently accepting documentation that was used during the 2018 submission period for the 2019 performance year. Also, if your EHR has been developed based on 2019 Prep 12 measure specifications, we will accept that documentation as well. I hope this answers your question. If you have any additional questions about documentation, if you could please submit them to the email address below. Thank you.
Great, thank you. All right, next question is from Martin Gems. So Martin, we've unmuted your line and you may go ahead.
Hi, thanks for taking my question. My question is in regards to Prep 5. It's pretty clear that the denominator exclusions would either be a bilateral mastectomy, history of bilateral mastectomy, or evidence of both a left and a right unilateral mastectomy. Now, as far as the mammography goes, pretty much the specs on page 5, 8, and 15 just say that mammography screening for breast cancer. There's numerous codes for unilateral mammographies that are available. Some specify left, some specify right, and some don't specify left or right. My question is, if a unilateral mammography is documented and there's no evidence of a unilateral mastectomy, is the measure satisfied? Basically, does a unilateral mammography satisfy the mammogram requirement regardless of the patient's medical history? Thank you.
Hi, this is Angie from PIMS. No, that would not satisfy the intent of the measure. The intent is that a bilateral mammogram is done for all existing breast tissue. You would have to have medical record documentation of a previous unilateral mastectomy in order for the unilateral mammogram to suffice. Does that answer your question?
Yes, it does. That's kind of what we were thinking, although it's really not specified that way in the specs. So thank you.
You're welcome.
All right, great. Next is looking for a clarification on Prep 7. It says Prep 7 is the only measure that you can close with claims data for the measure specifications, but we thought that an earlier response differed to that. Can you please clarify?
Yes, so again, Prep 7 has, you might find that there are some pre-filled yeses for Prep 7. In those cases, nothing else is required. However, if you don't have it pre-filled as a yes for a particular patient and you are trying to use claims data to say yes, that is also not acceptable. In the cases where it hasn't been pre-filled with a yes, you would want to confirm that you have medical record documentation that the flu vaccine was either received or there's an applicable denominator exception that should be selected, and then answer it in that manner. And basically what I'm trying to say is a claim alone would not be sufficient documentation in the cases when it is not pre-filled. Thank you.
Okay, great, thank you. All right, next question is from Lisa Kuhn. So Lisa, we've unmuted your line and you may go ahead.
Hi, thank you. My question has to do with Prep 13. How far back are we supposed to be looking for that active or history of the ASCVD diagnosis in their medical record? I know with the LDL, it says, do they ever have an LDL over the range? But with the ASCVD, it doesn't, it just says the history or active. I was wondering, like, as an example, if a person had that diagnosis back in 2016, but has not been diagnosed since, would we answer yes that they had the ASCVD diagnosis, or would we answer no?
So this is Deb, and I'm looking at the specification as well, and it does say that that diagnosis of ASCVD is active or history of any time up through the last day of the measurement period. So if you can find documentation of history of ASCVD, then you could confirm that patient due to diagnosis.
So even if it was 2009, you're saying yes. Okay, thank you.
Yes, you're welcome. Thank you.
Okay, great. Thank you. All right, and just a clarifying question on something that was stated earlier in the slides. It says, did I hear correctly that the denominator exclusion period for MH1 is anytime prior to December 31st, as the narrative specs on page 10 state prior to the end of the measure assessment period? So please reconfirm.
Excuse me, this is Katie from the PIMS team, and yes, you're correct. I did misspeak earlier. I apologize for that. So the active diagnosis requirements for bipolar disorder, personality disorder, schizophrenia, psychotic disorder, pervasive developmental disorder are any time prior to the end of the measure assessment period. So the start of that would be marked by the patient's index date during the denominator identification period, and then that 12 months plus or minus 60 days. And then for the second piece, patients who were a permanent nursing home resident anytime during the denominator identification period or during the measure assessment period. So I apologize for the confusion on that one. This is really to ensure that we don't assess an exclusion that occurs if it happens after the end of the measure assessment period. So these two periods could be different depending on the patient and when that index event occurs. Thank you.
Okay, great. Thank you for that. All right, next question is from Sandra Santangelo. So Sandra, we've gone ahead and unmuted your line, and you may go ahead. Sandra Santangelo, your line is unmuted, and you may go ahead.
Sorry. Thank you. My question is around PREV 10, tobacco use screening and cessation intervention. And I'm specifically looking for the documentation requirements for the cessation intervention. I understand that it's brief counseling, 3 minutes or less, and or pharmacotherapy. But what we're trying to understand, because we looked in the code sheets, we're not seeing anything. What needs to be documented? Like, does the physician have to say, I spent 2 minutes talking to the patient about quitting smoking, or can it just be discussed, smoking cessation or methods of decreasing smoking with the patient? Like, how specific does that documentation need to be in order to, count as cessation intervention?
This is Deb from the PIMS team. I think from our perspective, we can only give you the response from the measure specification as far as the measure does require brief counseling. It may be that you're looking for very specific documentation and what would be accepted. And I would say if that's the case, either maybe someone else on the phone can answer that, or if not, I would recommend opening up a ServiceNow case, and it could be answered through that format.
Yeah, no, I did put a ticket in, and of course, the question keeps popping up because they're trying to understand. We've read the measure, we understand what they're asking for, but it doesn't clarify, what qualifies it. So I guess I'll just wait for the response then.
Yeah, my apologies, and if we can, we'll talk and see if there's another way we can do this. But I think you're really looking at very specific documentation, and from the measure perspective, we could just tell you what the intent is. We cannot speak to what would pass an audit.
All right, great. Thank you for that. All right, your next question concerns PREV 6. It asks to please clarify the use of Cologuard for 2019 obstruction due to prior guidance.
Hi, this is Angie from PIMS. Cologuard for 2019 is a FIT DNA test, and it's acceptable, needs to be done during the measurement period or the 2 years prior to the measurement period to meet the intent. The slide from the 129 presentation has been corrected, so the correct answer will be posted when those slides are up. Thanks.
Great, thank you. All right, your next question asks, for DM pore control, what is the target or goal?
So for DM pore control, that measure is what we consider an inverse measure. And so the measure does say that if it is greater than 9, that is considered a performance met. However, because it is inverse, the closer you are to a 0% performance, the better you're really doing. So I hope that answers your question. If not, I would recommend a ServiceNow case, and we can answer a little bit further. But I think the main thing to remember about DM, the DM2 measure, is that hemoglobin A1C is considered an inverse measure. So if you get 100%, you have actually not passed the measure. You want to get as close to 0% as you can, because we all know that, you know, the A1C greater than 9 is really not the goal for a diabetic. Thank you.
All right, great. Thank you for that. All right, next we have a question on the phone line from Michael Levant. So Michael, your line is unmuted and you may go ahead.
Thanks. Can you please confirm that PREV 10 and PREV 12 measures are pay for reporting for the performance year 2019, please?
This is Kristen from RTI, and yes, PREV 10 and PREV 12 are pay for reporting for 2019.
Okay, thanks. And then just a follow-up question to that, because I wanted to double check about the tobacco one. I received documentation from KPP stating that it was pay for reporting, but then it said that it was pay for reporting for all Medicare shared savings programs, and I just wanted to clarify that that also includes NextGens, or is it specifically just for MSSPs?
PREV 10 is pay for reporting for both shared savings program and NextGen in 2019.
Okay, thank you.
And this is Lisa Marie. I also want to note it's also not scored under MIPS for groups who are participating in under MIPS. So I just want to highlight that it's not scored or it's paid for reporting across the board for all those who are participating via the web interface.
Great, thank you for that. All right, your next question is from Margaret Alcala. So Margaret, your line is unmuted and you may go ahead.
Hello, can you hear me?
Yes, you may go ahead.
Good morning. I just wanted to clarify, for CARE 2, would a patient reporting a fall during a visit, which may not be serious, suffice to meet the measure, despite not having documentation of a proper fall risk screening assessment within 2019? So them just mentioning that they fell within the year without having a proper fall risk screening assessment, would that be enough to meet the measure for CARE 2?
Hi, this is Olga from the PIMS team. For the CARE 2 measure, you would need to have documentation in the medical record of a fall screening during the measurement period. This can include a history of falls from the patient, a described fall, a note stating no falls, or an assessment of gait or balance. I do want to point out that in the event of an audit, the documentation you use would need to support that a fall risk screening occurred as it's defined in the posted measure specification. You don't need a specific screening tool, and additionally, you want to ensure that your medical record includes the documentation of the screening that was performed.
Oh, I see. So just for example, like a patient just mentioning in the chief complaint that he fell last week is not enough to meet the measure? Just wanted to clarify.
If you have a medical record documentation describing their fall and it's included, then that should meet the measure.
All right. Okay. Thank you for clarifying.
Sure.
Okay, great. Thank you for that. All right, next question asks, if you're unable to find an index PHQ-9 of over 9, will the patient be skipped?
Hi, this is Katie from the PIMS team. So for MH1, the measure denominator confirmation does require a PHQ-9 or PHQ-9M greater than 9 between November 1st, 2017 and October 31st, 2018. So in the instance the patient did not meet that threshold or they did not have a PHQ-9 administered, you would either enter the score or you would select no, that they did not have a PHQ-9 during denominator confirmation. So if no is selected, the patient is not considered denominator eligible. In that instance, the patient will be skipped and another patient must be submitted in their place. It's not necessary to request a CMS approved reason in these instances because the patient will be reported out during that denominator confirmation step. Thank you.
Great, thanks for that. All right, we just have one or two more questions on the phone line. As a reminder to anybody who would like to ask a question over the phone, please just raise your hand on GoTo by clicking on the green hand icon next to your name. All right, so your next question is from Tina Massinio. So Tina, your line is unmuted and you can go ahead. Tina Massinio, you can go ahead and ask your question. Okay, never mind. Next question is from Angela Winfrey. So Angela, your line is unmuted and you may go ahead.
Yeah, for PREB 12, if the patient had a positive screening and the provider recommended medication and the patient declined and all that's charted in the record, would that count as the follow-up?
Hi, this is Katie. So as long as there's documentation of the screening and the clinician's interpretation of the results is positive and documentation that the follow-up was recommended, appropriate follow-up as defined by the measure specifications, that meets the intent of the measure. The measure isn't looking for patient adherence to the follow-up plan, but just ensuring there's documentation the provider had a plan in place for that patient. Thank you.
Thank you.
Great, thank you for that. All right, your next question asks, for CARE 2, if gait imbalance is assessed with the responsive acts for documentation, can we take credit for this as full assessment being done?
Hi, this is Olga from the PIMS team. As previously stated, you do need documentation in the medical record of a fall risk screening as it's defined in the measure specification. This can include an assessment of gait or balance. And again, as previously stated, in the event of an audit, the documentation you use would need to support that a fall risk screening occurred. Thanks.
Great, thank you. All right, your next question asks, for MH1, for denominator exclusions of active diagnosis of bipolar disorder, personality disorder, schizophrenia, psychotic disorder, or pervasive developmental disorder, anytime prior to the end of the measure assessment period, what is the measure assessment period if a patient does not have an index event date, so PHQ-9 or PHQ-9M greater than 9?
Hi, so this is Katie again. This kind of goes back to what I was just speaking to previously. So if the patient did not have an index date, either due to not having the appropriate diagnosis for the measure or not having a PHQ-9, the patient is not considered denominator eligible. So when it comes to reporting on this patient, you would answer no to either one of those questions within the CMS Web Interface, and they will be skipped and you'll report another patient in their place. So if they did not have a PHQ-9 during the denominator identification period, they're not considered denominator eligible and they don't have an index event to continue reporting on. Thank you.
Great, thank you. All right, your next question asks, for PREB 7, what is the appropriate patient reporting requirement?
And this is Deb. Basically, what you need for the patient reported requirements is just documentation of a flu vaccine received during the appropriate flu season. So that could be, if I came in and I was reporting that I received the flu vaccine, I could say I received it in October and I got it at the Walgreens. So it's just anything that is showing that the patient received a flu vaccine during the appropriate flu season. Same thing could be said for, you know, the patient refusal. I think that's all you should need. If you have additional questions, please, you know, either ask again or raise your hand, and I'll try and be more clear. Thank you.
Great, thanks for that. All right, next question asks if they have documentation that a patient was 65 or older and was in an assisted living home during the measurement period, but they do not have data specifying the POS code 32, 33, 34, 54, or 56. Does the patient qualify for denominator exclusion?
Hi, this is Angie from PIMS. No, patients residing in assisted living would not be excluded. That's an exclusion for the PREV 5, PREV 6, and hypertension measure. Only patients 65 and older in institutional special needs plans or residing in long-term care with those POS place of service codes 32, 33, 34, 54, and 56 anytime during the measurement period would be excluded. You don't necessarily have to have documentation of the place of service code, but documentation that meets the descriptions of those codes is also sufficient. Thank you.
Great, thank you. All right, and this question was actually answered in the chat box, but we have been getting a few questions about it. So can you please clarify whether we are required to report on all 616 patients in a measure?
Hi, this is Azam. The minimum reporting requirement for each measure is 248. So you will need to complete consecutively all the beneficiaries that are ranked within 248. If you would like to report on additional beneficiaries that are in the oversample, you can choose to do so. Please keep in mind that any beneficiary that is reported on beyond 248 minimum reporting requirement will be included in the performance calculation.
And I also just want to note that if your sample for a measure is less than 248, you would report on all of the beneficiaries in your sample. So if you have less than 248, you must report on all of them.
Yes, and any additional information you would like to get on this, please take a look at the user guide on page 5. Thank you.
Great, thank you for that clarification. All right, we have 5 minutes left, but we did have one more question come through on the phone line. So Theodora Missouri, we are unmuting your line, and you may go ahead. Okay, Theodora Missouri, your line is unmuted if you'd like to ask your question.
I'm sorry. Yeah, I forgot to put my hand down after the first question. I'll put it back down.
No worries at all. Okay, we have another question come in from Matt Feynman. So Matt, your line is unmuted and you can go ahead.
Yeah, maybe I didn't hear the answer to this, but there was regarding hypertension 2, remote monitoring devices were not acceptable for 2019. Was there any information about being acceptable for 2020?
Hi, this is Katie from the PIMS team. So we would refer you to the 2020 CMS Web Interface measure specifications to review. Those are currently available on the Quality Payment Program Resource Library. So the HTN2 specification is available along with release notes outlining which sections of the measure changed. So we would refer you to take a look at that. And then if you still have outstanding questions on this particular topic, you can submit a case to qpp@cms.hhs.gov, and we can take a closer look at it for you. Thank you.
Thanks.
Great, thank you. All right, your next question is from Chris Lynch. So Chris, you can go ahead.
Hello, I just had a question in regards to claims data. So I know that claims data is used to put the individual into the measure, But if the claims data is coming from an organization outside of the ACO, do we just say no diagnosis if we don't have any medical records supporting that or any diagnosis supporting that diagnosis, or what are our next steps?
So this is Deb from the PIMS team, and I'll answer your question from a measure perspective, and with the understanding that you can't use claims data to confirm. You would want to find medical record documentation for any of the measures that require a diagnosis, that you're actually finding it in the medical records somewhere and not just within a claim. Same with any of the other information that is required, and that would really be across the board for any of the measures. As far as the intent of the measure is concerned and confirmation, you wouldn't be using just the claim, you'd be looking for the documentation. Does that answer your question?
Yes, ma'am. I do have a part two, well, just an example of that. So let's say for the PREP 13 statin measure, that the claims data is coming from another organization saying that they have ASCVD, but we have no record of that in any of our documentation for that patient. Is it okay to just put no diagnosis?
I think if you don't have medical record documentation, and I, if there's someone else on the phone can confirm this, but my understanding is if you have no other medical record documentation outside of a claim, you wouldn't use that to confirm. But CMS or Telegen, is that true?
Yeah, if you don't have medical record documentation showing that they have the diagnosis, you would select no, and that patient would be skipped and replaced in your sample.
Okay, great. Thank you for that. All right, we have time for one more question. So your next question asks, for MH1, if a patient does not have a screen above 9, will we still be required to enter the PHQ score even though it is 9?
Hi, this is Katie from the PIMS team. So the way the specification is built is the step of the denominator confirmation asks you to determine if the patient had a PHQ-9 or PHQ-9M score greater than 9 during that denominator identification period. So if they did have a score greater than 9, that's when you would enter the date and the score. If they did not have a score greater than 9 or did not have a PHQ-9 administered, then you would select no. So only in the instance where they did have a score greater than 9, you will be asked to enter that specific score. Thank you.
Great, thank you for that. All right, well, that concludes our Q&A. That's all the time that we have for today. So I will pass it back to Sandra Adams-Slaughter to conclude.
Thank you. Thank you all for joining us today. The slide deck recording and transcript from today's call will be available in the QPP resource webinar library in the next 2 weeks. As a reminder, our next support call is scheduled for next Wednesday, February 12th from 1 to 2 p.m. Eastern Time, during which we'll cover assignment and sampling frequently asked questions, as well as frequently asked measure questions about CARE 2, Hypertension 2, PREP 7, and PREP 10. We hope you'll join us. Thank you.